welcome. I'm Mackenzie Peterson. I'm an organizational well-being and strategy consultant and the former director for well-being at the American Association of Veterinary Medical Colleges. I'd love to invite our three panelists to come up. Cha-Cha Chang, Jessica Judley, and Margot Brooks-Carden, please. Now for session 2, we are going to be talking about data. I know that feels like maybe the most boring thing, but I hope everyone in here is as excited as we are. We're a little bit of the data junkies, so we know that the amazing stories that we've heard earlier today data helps us know about the prevalence of these stories. So we're really excited about that today. So within this, I'm going to do a little brief introduction for everyone. So I'd love to welcome Cha-Cha Chang. She's a coordinator of the NEOSH Office for Total Health Worker and the NEOSH Healthy Work Design and Wellbeing Cross-Sector Program. Dr. Jessica Dudley is a Chief Clinical Officer at Press Ganey, and Dr. Margot Brooks-Carden is an Associate Professor of Nursing and Chair for Gerontology Research at the University of Pennsylvania. We will initially start with Dr. Chang.
Thank you. We're keeping our remarks short, so we'll have a discussion. There you go. Can you hear me? Yeah. All right. Thank you. Thanks. I'm Cha-Cha from NIOSH, National Institute for Occupational Safety and Health. We're part of the CDC, so we do research. We make recommendations, as CDC does. We're not part of the Department of Labor. We don't do regulations like OSHA, but we were created by the Occupational Safety and Health Act, so we care about worker safety, health, and well-being. I think we had slides. Oh, is there control? Oh, thank you. Oh, there you go. All right, thank you. I'll give a little bit of the overview. The plan is to provide this overview sort of like from a national perspective. First, I'll just be clear in saying there's no surveillance system for well-being. There's no surveillance system for worker well-being. There's no data necessarily or metrics about DEI, and there's certainly not DEI of well-being of healthcare workers. So we're just going to get that out there. A little bit of what we do know. So there are some data. This is just an example of some of the data we have. This graph, it's very small, but it's just an example of what we do know. It shows the 25 largest healthcare occupations by race in 2022. And we know that about, in general, a fourth to a third of healthcare support workers were Black. This includes nursing assistants, licensed practitioner, practical and licensed vocational nurses, home health aides, personal care aides. So that's about a fourth to a third of health support workers are Black. If you compare it to the overall workforce, Black workers account for about 12% of employment in all occupations. Similarly, Hispanic workers make up about 19% of total employment of all occupations in 2022, but accounted for a large share, again about 1/4 to 1/3 of similar positions, medical assistants, home health aides, dental assistants. There's separate data on foreign-born workers. Foreign-born workers make up a large share of home health aides, personal care aides, and physicians. And then there's some data about age, across different age groups. Home health aides, interestingly, a large share of home health aides were ages 55 and over, compared to the general population of people who are 55 and over. It's about 36% versus 24%. Also in the older age group were physicians. Youngest, in case you're interested, are the assistants. Veterinarian techs, pharmacy techs, nursing assistants, dental assistants, medical assistants. Interestingly, now we'll talk a little bit, this is a different slide. Again, this is just sort of a sample. About 70 to 80% of workers in healthcare occupations are women. This is different from the general population, which is about half are women. And women are slightly underrepresented among physicians. That's about 44%. This chart shows the median earnings of healthcare occupations. It shows what we know intuitively, which is that certain jobs pay more. Women working as registered nurses have a median annual income of about $68,000. So the interesting thing is to combine this with the other data so that we know that workers who are Black and Hispanic and women are in the occupations with lower earnings. So that's all interesting from DEI, and also related to well-being. What does this mean for well-being in general? Interestingly, this slide also shows, I know you can't see much, that in general, men make more than women, even in, within each category. And one final thing, for whatever it's worth, we know physicians get paid more. Physicians also work, this is not on this slide, but other data. Physicians in general work more hours than other occupational categories. I think it was about 48 hours. And if you want to know, the ones who work the least are the massage therapists and dental hygienists, who average about 30 to 33 hours. So this is the data we have from the Census Bureau, who collects data through the American Community Survey, an annual survey, and also they collect data through the current population survey, and that's for the Bureau of Labor Statistics in the Department of Labor. So that's just sort of that type of information. So we know information about demographic groups, hours of work, earnings. And then there's also health. So these haven't asked about health, right? So the CDC has a National Health Interview Survey that collects a lot of information about health behaviors, health status, and includes some work issues like hours worked, harassment on the job, do you have access to paid sick leave, do you have access to paid health insurance? So that's health. And then there's also separate surveys about working conditions, which is what we are interested in here. One example would be the Quality of Work-Life Survey. That is administered every 2 years in the General Social Survey that's done by the University of Michigan. The General Social Survey is every year, but only once every 2 years, because we don't have funds. Once every 2 years, the Quality of Work-Life Survey. That includes questions related to work: culture, climate, health conditions, hours of work, work overload, autonomy, insecurity, job satisfaction, job stress. Use of technology at work is one of the new questions we've added in. Supervisor roles. If you were here for the morning session, Dr. John Howard talked about the latest vitality report, the MMWR report that was released last year. That was based on analysis of the Quality of Work-Life Survey, where they found that health workers face a mental health crisis, and that working conditions, such as supervisor support, made a difference. So we've talked about sort of data, numbers, we've talked about health, we've talked about quality of working life, but there's nothing that brings it all together. I will give a little plug. Oh, so that's it. There is now the National Worker Wellbeing Questionnaire. So that includes a section on working conditions, some of the things we've talked about. It has a section pulling a lot of questions from the National Health Interview Survey asking about health. And it is a free tool for public use. It's based on the definition of worker well-being that is in the book, that's in everybody's book. On table, it has a definition of worker well-being and identifies 5 domains, including health and working conditions. And this is just a tool for other people to use. We're not administering it. The government is not administering it. There's still no data, right? There's still no surveillance. It's just out there for people to use. One thing that is useful for something like this and all the other things I've talked about is that these are not specific for healthcare. And the good thing about that is that then you could make the case of comparing healthcare industry, healthcare workers to other workers. If you want to know, are we doing worse than other industries? You have that data versus if you're just using a survey that is just for the healthcare worker, you would lose that. And the National WellBQ has just the questions. There's not a separate section on demographics, but of course, if you administer it, you could choose whichever demographic questions you want to ask that's relevant for you. And as with all data collections, you really want to be careful about privacy. People certainly don't want to answer questions if they're not sure that the information is going to be protected. The National WellBQ does ask, it's about worker well-being in general, but it does ask questions about, have you felt discriminated against because of your age, gender, race? Do you feel like there's been incivility at work? Do you feel like you've been put down or treated with condescension? And also, have you been harassed, bullied, and threatened at work? I'll end with just a couple of things. One is one of the things that we do at work at NIOSH, we also do work by sectors. So we have a healthcare sector program that's led by Dr. David Weissman, who's part of this action collaborative. And the sectors also develop national agendas. The sector isn't a NIOSH thing. We bring stakeholders, partners from the industry in, and people identify priorities for the country. Not priorities for NIOSH, but priorities for the country. And increasing surveillance and understanding and collecting data about these issues is a recommendation. And also it's interesting to know how we do compare to the other countries. Other countries do have some data collection about well-being, not specific to workers, and we don't quite have that exactly. That's it. Thanks.
Can you guys hear me? Yeah.
A little closer.
What am I supposed to do? It is green.
Okay.
Okay, great.
It's not as green as this one.
It's light green.
Okay.
Pale green. Hi there. Thank you. Thank you for the introduction. I'm Jessica Dudley. I am the Chief Clinical Officer for Press Ganey. I have so enjoyed this day so far, and there's so much overlap between both what we heard this morning and even the last panel. I am going to keep my remarks right now focused mostly on the data that we've been collecting on diversity and equity, as well as respect. Didn't actually realize the first panel, and then the discussion even before that was going to go so deep into that, and I think it's fantastic because this is all so connected. So Press Ganey, many of you guys may have heard of us. We do a lot of surveying of patients, but we also do a tremendous amount of surveying. You keep pointing to me and I'm doing something wrong. Push the button. Oh, duh, sorry. Thank you. I'm sorry. Thank you for the help. You were great. You were. I'm sorry. Okay. So we survey patients, but we survey about 1.2 million employees. Actually, sorry, 1.6 million employees annually, about 120 to 140,000 physicians, and about 40,000 APPs. That's kind of our normal annual survey. I'm going to show you a few slides of diversity and equity and its relationship to engagement. So for our workforce survey, we measure engagement, culture of safety, and we consider DE&I part of safety culture. The reason why this slide I'm showing you is important is you can see on the x-axis it's giving you the diversity and equity module score. We have 5 questions. I'm going to show you them in a minute that are capturing an individual's perception of their sense of diversity within the sense of inclusion that they have within their organization, their manager's commitment to equity and inclusion, and their organization's commitment to that. On the y-axis is engagement mean score, and that's a cluster of 6 questions that are capturing really pride in the organization, and it's about kind of a willingness to go above and beyond for your organization. So it's way more than just kind of am I not burnt out and am I doing well? It's how committed am I and proud am I of our organization. These are important because engagement is directly tied to things like turnover. So when your engagement scores are low, your turnover is really much higher, markedly higher actually. We just released data last week on this. It's also directly correlated with patient experience and safety outcomes. And I'm not going to show all that data, but the purpose of this slide is to show you. So if you move to the right part of the slide, for every single race and ethnic group, this correlation, this relationship to do I feel that my organization is supportive of diversity and equity, it is completely correlated independent of my race or ethnicity, whether I'm white, black, Hispanic, or Asian. That correlation exists. So this is important to everybody in the workforce. This is not just a minority issue. This perception of feeling connected and included is important for everybody. So this is our most recent data. This is from this past year, and it actually is a data set of 2.2 million employees, and it's comparing how they scored on the diversity and equity module with how they scored it the prior year. So the first thing that you can see is that by race and ethnicity, there's a range of scores. It's on a 5-point scale, and a 0.01 to 0.02 difference is significant. So as you can see, Black, African American, or American Indian, or Alaskan Natives are scoring their perception of the organization's diversity and equity much lower than white or Caucasian. And you can see, so glass half full for a moment, there is some positive movement. There's been some increase, and I think this is due to the work that organizations are doing in this area, which is great, but it's not across the board. So there are cohorts where it's actually gotten worse. I threw this in, I'm a female physician, and I think this is important. So the healthcare workforce, Tatcha was just sharing with us too, mostly women, except for physicians, where it's a little bit closer to 50-50. And you can see here, though, so good news, glass half full, everything's improving. Everybody's scoring these questions higher. But for physicians, there's a big gap between female physicians' perceptions of diversity and equity versus male physicians. I know the data, and it's actually much worse for African American female physicians. Okay? So these are the questions that we're capturing with diversity and equity, and this is this kind of turnover question and why this is so important. So if an employee scores these questions low, these are the 5 questions that we're asking, so if they give them low scores, then their likelihood of wanting to stay with the organization falls dramatically. So when I don't agree that the organization values employees from different backgrounds, then my risk of leaving if I'm offered another job is 4.6 times greater than somebody who actually perceives that the organization does value employees. This is really important. I'm sure everybody is aware, like staffing and retaining who we have right now is so important. So then I was going to switch to respect, because as much as the diversity and equity data is so important, I wanted to move this a little bit from just social justice to organizational culture, because it's really a big deal. How employees perceive being respected is the #1 driver right now of whether or not their engagement is going to move up or not. And you can see that by different job professions, folks feel respected very differently. And again, on the glass half full, you can see from 22 to 23, positive. We're moving in a positive direction. That's fantastic. But there's a huge range of how different job perceptions perceive being respected by their organization. We were talking about this at my table earlier. Like, I'm really worried about APPs. I'm worried about everybody. And we need to be worried about everybody. And even though we've made big strides this past couple of years with registered nurses, you can see they're still at the bottom. Okay, I threw this in because, and I'm looking around the room, we are a mix of ages. I am in the upper quartile, I think, of the ages in the room. But okay, maybe not. I'm close. I do think I'm in the close to upper quartile, because there's a lot of young people that are bringing us down in this room, which is great. So, okay, so this slide is important because, first of all, millennials think differently, and they feel less respected. These are 3 lines here. One is my manager treats me with respect. This is actually good news, and this is really important. So folks really do feel like people who are still working in healthcare feel like their manager is respecting them and that they respect their manager. And that's good. And even though, again, millennials are lower scoring, it's not as dramatic as how we see everybody is scoring the perception of respect by the organization lower, and especially millennials. This is just the trend line of what's happening with respect. And again, positive, we're moving up, except and even with this organization treats employees with respect, but there's a big gap. So this is my last slide. And this is just showing this relationship, and it was actually mentioned in the prior panel as well, that if part of the goal here, in fact, we said, and many people have said this, like, we're in this to reduce suffering for patients and deliver excellence in care for patients. That's why we all are here and choosing to work in healthcare. If that's what we're going for, and that's the y-axis here, that for you to be kind of consistently in that 83rd or 79th percentile for patient experience, you need to be there with respect for your workforce. There's this direct correlation between how the workforce feels respected and how patients are experiencing their care. Okay, thank you.
Good afternoon. Oh, you can hear me. Can you all hear me? Okay, thank you. So thank you to my panel, my colleagues on the panel. It's such an honor and a privilege to have had an opportunity to share this day with you. This has been a personal passion of mine for some time, and to share the space with others who are equally engaged in this work has just been a highlight, and to be here is even more of a privilege. And so thank you for the introduction. I am Margot Brooks-Carthon. I am an associate professor of nursing, and I've been a nurse for probably nearly 30 years. Dr. Malone was the dean of the School of Nursing, so I've known her since I was 18. And so as without giving away our ages. So in addition to being a nurse, I'm also a researcher, an equity researcher, and I'm the associate director for the Center for Health Outcomes and Policy Research at the University of Pennsylvania. And our founder for CHOPPR, as we refer to it, was Dr. Linda Aiken. And so many of you in healthcare may know Dr. Aiken's name because much of the early work that we know regarding nursing and burnout came from her and the CHOPPR team. When I joined CHOPPR, I was a postdoctoral fellow, and I was very interested in understanding the ways in which nursing and staffing in the work environment influence the outcomes of historically marginalized populations. So I'm an equity researcher by training, and I've been welcomed into the CHOPPR family. And one of the threads of my research is interested in the well-being of minoritized nurses. And so Linda would say, and I will also share, is that burnout is not new, that COVID amplified a long brewing crisis. It's important for us to focus on nurses. As we've heard, there are nearly 5 million nurses in the US. During the height of the pandemic, at a minimum, 50% were reporting burnout, 1 in 3 intent to leave. And I would argue that those are underestimates. I think Dr. Cipriani mentioned up to 75% of nurses at one point in time experiencing or reporting burnout. And so my work and that of others has showed that as alarming as those figures are, that nurses of color disproportionately experience higher rates of burnout, higher rates of intent to leave, higher rates of emotional exhaustion, higher rates of discrimination, racism, and bias. And because of that, we have a crisis within a crisis with a lack of interventions to directly address these concerns. And that is the focus of my time that I'll talk with you about today. And so when it comes to intervention development, of course, many of us in the room are researchers. We have to begin with our why. And so if we want to think about interventions to address burnout and emotional exhaustion and intent to leave among nurses of color, we first must ask ourselves, why are they experiencing such high rates? And in order to do that, we need data. And so you would think that Jessica and I planned our slides. We did not, but there are certainly areas of concerns that she raised that I will now amplify. So one, yes, we need data. I would argue that as we collect data, particularly in respect to nurses, that we also need data that cuts not just across demographic groups, but also looks within, right? We're not monolithic. And so as we think about intersecting identities, as we think about age, that it's important for us to disaggregate much of the data that we collect to look within. In addition to looking at our data differently or dissecting it differently, I'd also argue that we need to explore more explicitly the diverse roles within nursing. Much of the focus has been on the role of registered nurses, which has left unanswered questions about licensed practical nurses and advanced practice nurses. And so if you saw Jessica's slide, you'll know there is deep concern among advanced practice nurses. I am a nurse practitioner by training, but there is not a lot or a good deal of data around burnout and emotional exhaustion among APPs. In addition to our need to examine differences across roles, there's also a need for us to examine these differences across settings. Much of the attention has been placed on nurses who are working in acute care, which leaves open questions related to providers who are working in community settings, primary care, particularly those providers who are working in medically underserved areas. This has direct consequences on the health outcomes of the patients who are often marginalized that they are caring for. Finally, as someone who engages in mixed methods research, I would also encourage us to continue to mine the story through interviews and other forms of collection beyond that of just surveys. It is important that we interrogate the message underneath the numbers and allow ourselves to get context for the personal and the professional experiences of underrepresented nurses. The work of our team, particularly during and in the aftermath of COVID, sits at the intersection of our need to explore the experiences of diverse nurses. And so I'm going to share a little bit about a study that we conducted, and it was published in November of 2023 in the Journal of the American Association of Nurse Practitioners. You can read from the title, "I Had Become Fed Up, a qualitative study of nurse practitioners' experiences fighting against health inequity, racism, and burnout." The purpose of this study was personal to me because as a nurse practitioner during the pandemic, I often wondered, where are the reports about what nurse practitioners, particularly nurse practitioners of color, are doing during the pandemic? I know we were out there, I knew we were out there, but I just saw so very little coverage about the work that we were doing. And so we had a grant from the Robert Wood Johnson Foundation that allowed us to ask two central questions. What were Black nurse practitioners doing to address health inequities? Question one. And what were their organizations doing to support them? Question two. What we learned through these interviews of 16 nurse practitioners who self-identified as Black or African American was their deep, deep commitment to addressing health inequities. We learned about the strategies and the tactics that they took to address health inequities while employed in their clinical settings. And I'll say that these nurse practitioners were working across the lifespan in pediatrics all the way to adult health, and they were working in the acute and the community spaces. And so they told us some nurse practitioners were working with migrant farmers, and they would go out to local bodegas to see the food in the grocery stores where their patients could get groceries to make sure that when they were providing clinical care, that they would be able to counsel them in a way that was congruent to what they could access. They told us how they wrote letters that, quote, "I had become fed up," was a direct quote of a nurse practitioner who was tired of seeing her patient wait for hours and hours before they could be scheduled to be seen. How they could see that the aesthetics of the clinic where they worked for their Medicaid patients looked very different than the aesthetics of their private pay and commercially insured patients. So they become so fed up that they were writing letters to their administrators. They were holding committees and conferences on DEI. They were teaching their colleagues how to be anti-racist. This was on top of their clinical jobs, caring for patients. And they told us about the toll, the passion to do the work, and the toll that it was taking on them. I just want to share a few of their direct quotes. One of them shared directly, "I am passionate about it. That's why I keep doing it. I'm committed to it. That's why I keep doing it." At the same time, recognizing that much of this work was in addition to their clinical jobs of seeing patients, which equals uncompensated labor. And so another participant said, "I'm doing that on my own time. Nobody is giving me support for this." And when we asked directly about the support of organizations, they often said, "It's largely lip service. We're not seeing the support." But what kept them hanging on was a passion, but the toll it took, which we heard repeatedly, was causing them to rethink their clinical roles, rethink their places of employment. And so finally, a participant, which was heart-wrenching, said, "You're invested into it because it's something that's so important to you, but it's emotionally taxing and draining and leads to this burnout. And eventually, that's like, I can't do this anymore." And so in nursing, we are facing a crossroads. At the same time that we are trying to diversify the nursing workforce, we have nurses who are critically thinking their professional choices. And I often say that nurses are the canary in the coal mine. And so when nurses say they're burnt out, when they say they don't have enough staff, when they say their work environments are suffering, you can bet your last dollar that patient outcomes follow and that minoritized and marginalized population outcomes suffer most. So these accounts were rich. The interesting thing about it is we did not ask about burnout. We did not ask about emotional exhaustion. We did not ask about racism. We did not ask about bias. Imagine if we had, right? So that's the importance of when we have the data asking the questions. We got this asking a completely different set of questions. So imagine if we are targeted, right? If we are specific. And imagine if when we get the data that we have the moral courage to actually follow the data and do something about it. And so that led us to think about, well, what are the solutions? What does the evidence say? What's out here to address this crisis among minoritized nurses and burnout and their emotional exhaustion? Imagine my surprise when we found there is very little. In fact, there was literally nothing that we could find about this very specific challenge and this very specific crisis among this very important specific population. And so necessity is the mother of invention. A few weeks ago, the University of Pennsylvania School of Nursing and Chopper, where I'm the associate director, we held an inaugural invitational convening. We had leftover money for this RWJF funds, and we asked if we can convert that funding to a convening where we brought 40 stakeholders together. The primary reason to bring these stakeholders together is that we wanted to invite back the people who were a part of our study, right? So we told them when we did the study, we're not just coming in to interview you and put our, report in a journal somewhere. This is the start of a larger conversation, and we are going to work together collaboratively to address health inequity. Well, what happened is we have this convening to say we need to work collaboratively to make sure you all are okay. Because what we didn't expect to hear was how tired you were, how exhausted you were, how you need community too, because you're out here by yourselves a lot of times doing this work. And so in bringing this group of practitioners and scholars together, it was largely to begin a conversation and a movement to ensure that the people who are doing the work of DEI are themselves supported, that they are not just at the table, but they're leading the conversations and setting research priorities, fostering collaboration, because in addition to us thinking about collecting the data and developing interventions, we have to be sure that the people who are affected are the ones who are deeply involved and invested in the data collection and the intervention development. So, thank you.
Thank you so much, everyone on this panel. Just, I know we're unable to do the initial last question like how we had planned, but just to sum up a few key takeaways that I think that the group can see right now, I think we obviously see a need for greater data collaborations at the national level. We need a little bit more comparing apples to apples and oranges to oranges. Secondly, we also see that organizational data should include demographics and well-being and topics about workplace culture. I think Jessica highlighted that beautifully, that we need to look at the experience to really get the full picture. And then, as Margot said, different groups can and usually do have different experiences in the workplace. There's power dynamics involved, and that we shouldn't underestimate the richness that qualitative data focus groups can provide for us. Because what have we seen them say? They're not asking for yoga and meditation. You can't downward dog your way out of a bad boss. You can't meditate away racism and sexism. So thank you so much, everyone on the panel, for really highlighting what data really empowers us to be able to do.